Shortly after we launched the campaign, I went to Nottingham to visit Professor Rowan Harwood, whose work on engaging families and other carers in order to help patients with dementia and delirium has been central to our understanding of the issues involved. And I was extremely moved, bowled over by my visit to him and to his ward. But the title of his talk today is his rather kind rebuke to me, which is, there is more to this than just being nice.
Thank you. So Nikki was kind enough to describe her visit as a watershed moment and asked me to explain why I do what I do. It's quite easy, really. I'm an NHS consultant, so I want to provide the best possible service for patients and their families. And I'm a clinical academic, so I want to provide ideas and evidence that others can use to support making things better elsewhere. But I thought I'd share a few things from my world, some things that might be of interest. It shouldn't be contentious that family members and other carers, I have to be careful here, that in one of these studies, the first patient I recruited, I went up to this lady and asked her about her husband, and she told me, I'm not his carer, I'm his wife. So family members and carers is what I'm going to refer to people as. It shouldn't be contentious for anyone who has difficulty giving or receiving information, understanding information, or using that information, or advocating for themselves to need support. And in theory, that's well recognized. So here we have 3 models that we commonly use when caring for frail older people. We've got comprehensive geriatric assessment, we've got person-centered dementia care, and we've got palliative care. And all of them have embedded the notion that you're going to involve family members. In fact, we might have the Mental Capacity Act. You can't abide by the law without involving family members as well. So why is there a problem? We've done a series of studies of people with dementia in hospital, and there are some complicated things going on. First of all, who is a carer? We found that 10% of people with dementia in hospital had no one. There was no family, there was no neighbour, there was no friends who we could find despite an awful lot of looking. And a study from London suggested that the figure was 20%. And these are often people who are living by themselves. Of those who did, 25% were a spouse, 40% a son or a daughter, and 25% were other people. So this is siblings or nephews or nieces or friends. 32% lived together, 40% apart. In 28% of cases, the person was living in a care home, so a different sort of relationship again. 73% were the sole pet carer, and in a third of cases, the carer themselves had health problems. So I think this demonstrates that although we've got an awful lot to learn from the experience with children, this is even more complicated. One major theme that's come out of interviews is about the impact of the sudden disruption to routine for both patient and family carers that an illness or admission to hospital causes. And in response, everyone, the carer, the patient, staff, and other patients on the ward try to do things to restore or give a sense of restoring control. And this could be constructive, or it could be disengaged, or it could be distressed. So a range of different responses all going on at the same time, again, making things really quite complicated. Family members, we found, for the most part, tried really hard to help both staff and patients. For example, by maintaining routine or making up for deficiencies in the hospital system. They'd use their knowledge, they'd use advocacy, or they'd get involved with hands-on care. And family members also wanted to retain their own sense of control over a difficult situation. and they'd do that through actions, such as monitoring care, and sometimes questioning or complaining, sometimes creating alliances, trying to get support from other people who can help, or helping with the arranging of community services out of hospital. And they'd also think it through. There was a lot of rationalizing of what was going on, both with the patient and how they were behaving, and with the staff and how they were behaving. One very specific analysis that my colleague Fiona Jurgens did was to look at why some family carers became so unhappy, so dissatisfied. And she came up with this idea of this cycle of discontent. And the cycle started with events or crises brought on by an illness or injury, but with a run-in that often leads up to the crisis. So often by the time somebody got to coming to hospital, the family carer was exhausted. And they'd also bring with them a legacy of bad experiences from prior hospital admissions. With events came expectations. Now, sometimes these expectations weren't realistic, but very rarely did staff actually find out what the expectations were. And the consequence of that was that the expectations were usually unmet. And that led to suspicion or uncertainty. And suspicion or uncertainty led to looking for new problems that are in the system, what we call hypervigilant monitoring, seeking out problems. And that in turn would lead to conflict. And a conflict is another crisis, and so we went round the cycle again. Now, the scary thing about all this was people were round the cycle even before they'd left the emergency department. And they'd often round it again when they went through a medical admissions unit. So that by the time a patient arrived on a ward, the staff were faced with angry relatives. And so the staff were immediately on the defensive. And in fact, some staff became when we've discussed this with staff, became rather very upset that people didn't appreciate the position that they were in. We've also interviewed staff formally. Staff are very aware of their limitations, both in terms of knowledge and the environment in which they're working. But they're often apprehensive about putting themselves in difficult situations, making themselves open to criticism, or saying the wrong thing. And that would often lead to them actively avoiding communication with families. But of course, that's exactly what we don't want to be doing. This sort of model leads us to some very practical recommendations about how to make things better. So make each hospital contact positive. Proactively seek opportunities for communication rather than waiting for the family to have to make the approach. View the carer and the person with dementia as a single unit. Make systems more dementia friendly. And look out for those with no carers. In 2009, funded by the National Institute for Health Research, which is the research wing of the NHS, we developed a ward that aimed to try to embody all the aspects of best practice, and that's what Nikki came to visit. So we took an acute geriatric medical ward. We introduced some mental health professionals to work alongside the physical health staff, and that process of learning how to work there went both ways. The mental health staff had to learn a lot from the physical health professionals as well as the other way around. We made some adaptations to the environment. All the staff were trained quite extensively in person-centered dementia care. We introduced a program of activities under the supervision of a mental health specialist, occupational therapist, and we deliberately adopted a proactive and inclusive approach to families. And what does that mean? Well, it means the giving and the gaining of information from each other. It means learning about the person's background. It means being open to people being involved with everyday care. And first and foremost, it means making your visiting times somewhere between free and liberal. We introduced new documentation This issue about how much the families of people with dementia in hospital need a break is a very real one. And obviously the answer is to ask people. So we introduced this form, Caring Together, which asks what the role of the person was before the person came into hospital and how they want to continue to be involved. And that might mean asking whether they want to be called in the night if the person is distressed or whatever. I think we have to respect the family member's own position and not make it an obligation. So after developing the ward for a year, we ran a randomized controlled trial. So we had 600 participants who were randomly allocated either between the ward and standard care. Now, standard care actually was 70% specialist geriatric medical wards. Obviously, a lot of my colleagues have exactly the same mindset and goals as I do. So maybe the difference wasn't as great as you would have wanted for an experiment. But when we looked at what was recorded, we found that there were definite differences in care, including greater family communication. Our main outcome measure was the number of days spent at home in the 90 days after we'd recruited someone, and we increased that by 6 days from 46 to 52. Now, a lot of things weren't different, and obviously the system wanted reduced length of stay and reduced readmissions. We didn't get that, but we did get better patient experience, which we got from direct observation using a structured tool, and better carer satisfaction. It was actually cost saving as well, so it should have been a win-win. Although disappointingly, this has been sold as a negative trial by other people, not by me. We didn't please everyone. This is the proportion of carers. This is a blinded telephone call, so the person taking the call didn't know what the care somebody was getting was. But still, 5% of our families were very dissatisfied. But when we looked at care overall, on the specialist unit, 91% of people were very or fairly satisfied, and it was 83% on standard care wards, so possibly not as bad as one might anticipate, but still 17% of people who weren't very satisfied. A couple of things to note. A fifth of people said that the discharge was premature. 30% of people said that they weren't prepared for the discharge. And even though we went to immense efforts to try and communicate with our families on the ward, 11% still said it was too much. And it wasn't enough, sorry. And one of the things we learnt was that it's the amount of communication that families need is really immense. If you prefer your evaluation a bit more human, here's some. People do notice and appreciate good care. I want to emphasize this was an acute medical ward. It's busy, there's lots of sick people, not everyone does well, and some people are coming to the end of their life. But what we did show was it is possible to make acute hospital care better adapted for the needs of people with delirium and dementia and their families. I said I'd mention some challenges. Hospitals still run on this acute medical model. We heard about sort of reducing unwarranted variation. Hospitals are under immense pressure to get people through. And it almost makes care like an industrial process. People talk about lean models and so on, which we've got from Toyota. So we're trying to make our wards like Toyota's production line. And that sort of strips out anything that isn't seen as or perceived as contributing to a quicker discharge. And of course, that's not exactly what people with dementia don't need. We need to emphasize these more person-centered aspects, the relief of suffering, the good experience, taking sensible risks, involving families rather than just individuals, and indeed other stakeholders such as care homes. Concentrating on function and behaviour, individualising care, and trying to provide some sort of continuity in a very fragmented health service. A few years ago, the Care Quality Commission came up with this nice list of things that you need to deliver dignified care: leadership, attitude, skills and resources, and I think they got it spot on. They're all important, but when we look at the job of somebody like Janice Sigsworth or any other person in a senior nursing position, they are under multiple and very intense pressures from lots of different directions. And if we're going to get this right, we need a social movement. And that's what John's campaign is. People like Janice need support of people making the case for doing things differently. And so I want to thank Nikki and Julia as well. I want to thank all of you for your advocacy and support in making hospitals less scary places for people with dementia. Thank you.